Thank you. I'd like to welcome you to this meeting of the Health and Wellbeing Board being held on Monday the 15th of December 2025. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing that it does not disrupt the business of the meeting. With regards to the microphone, for participants in the room, please raise your hands to indicate that you wish to contribute. When invited to speak, press the button on the right of the microphone unit and speak directly towards the microphone. Please remember to turn your microphone off once you have finished speaking. And please ensure that mobile phones, laptops and other devices are turned to silent. For participants in attendance remotely, can I request that you use the raise hand feature within the system if you wish to contribute and to introduce yourself when called upon. Please note that only board members present in the meeting room may vote. We now turn to the agenda. So item 1 is apologies for absence.
Thank you, Chair. Yes, apologies for receipt. Well, Kevin Crompton, Herefordshire Safeguarding Adults Board, may be late, but otherwise sends his apologies. Also had apologies from Sue Harris of Herefordshire and Worcestershire Health Care and NHS Trust, Tina Ross on this far of Herefordshire Council, Simon Trickett, NHS Herefordshire and Worcestershire Integrated Care Board, and also I note that John Butlin of Hereford and Worcester Fire and Rescue Service and Christine Price of Herefordshire Health Watch can't attend in person but are in attendance remotely, so are able, as you mentioned, to participate but not vote. And finally, we've also had apologies from Councillor Pauline Crockett, Chair of the Healthcare and Wellbeing Scrutiny Committee.
And do we have any substitutes?
Yes, thank you, Chair. We have Hilary Jones, Head of Additional Needs, kindly in attendance for Tina Russell, Corporate Director for Children and Young People.
And do we have any declarations of interest?
No.
So before I move to item 4, I would like to introduce you, to those who don't know, to Sarah Shingler. So she will be my Vice Chair for these meetings. She is the Managing Director of Wye Valley Trust and will also be my Vice Chair. For those of you who do not know her, I believe it would be useful for her to give you a brief summary of her previous experience. Thank you.
Thank you. I wasn't forewarned. First lesson. Okay, hi everyone. So I've been in post now, coming up to 10 weeks at Wye Valley as the Managing Director. Previous to that, I was the Chief Nursing Officer at Worcestershire Acute Hospital. So I'm not completely new to the system or the Integrated Care Board. I've worked with them for the last 2.5 years. So I am a nurse, obviously. I'm also still practicing as a nurse consultant in emergency care and critical care and still work clinically over in Manchester. Background of Chief Operating Officer roles, joint roles across health and social care over in the Northwest. So very much around transferring services from an acute setting into community and other settings, and working around quality and safety and with some of the national team. So that's me in a nutshell. Thank you.
Okay. Before I go around the room and you introduce yourself for those people who are listening online, I'd like to welcome Councillor Ed O'Driscoll along to this meeting. We don't, as a rule, have members of the council who are not chairs of health scrutiny along to these meetings, but I felt on this occasion he recently proposed a motion at the full council for the reopening of the minor injuries units, and I thought it was only right to allow him to speak on that particular item following the presentation. I'd like to make it clear that I would offer a similar opportunity to any member who proposed a motion in council which was accepted and became the motion and was related to an item that referred to the Health and Wellbeing Board. So thank you. So if I go around the room now, if people could introduce themselves. So I'll start with Steve.
Thank you, Chair. My name is Steve Bedser, and I'm part of the Partners in Care and Health programme commissioned by the Local Government Association. I'm here as a visitor to talk to one of your agenda items.
Zoe Clifford, Director of Public Health.
Rob Davis, Consultant in Public Health.
I'm David Collier. I'm a consultant in public health and a local GP.
Jo Hodgetts, I'm Associate Director of Neighbourhood Health for Wye Valley Trust and One Herefordshire Partnership.
Katie Thompson-Dixon, Head of Resilient Communities in Public Health.
Councillor Ed O'Driscoll, I'm Chair of the Connected Communities Scrutiny Committee and Chair of the Connected Communities Scrutiny Committee. Thank you.
Hello, Hilary Jones. I'm the Head of the Additional Needs Service at Herefordshire Council and I'm representing Tina Russell.
Hi, I'm Steve Brewster. I'm the Chief Executive of Active Herefordshire and Worcestershire, but here today is the VCSE representative.
Jonathan Lester, Leader of Herefordshire Council, and I could confirm that there are only 10 more sleeps until Christmas.
Hilary Hall, Corporate Director, Community Wellbeing, Herefordshire Council.
And finally, David Mahaffey, Director of Strategy at the ICB.
And I'm Councillor Carol Gandy, Chair of this committee, but also the Cabinet Member for Adults Health and Wellbeing. Thank you. So we move on to item 4, which is the minutes of the meeting held on the 15th of September. Can I confirm that can anyone confirm that is a correct record of that meeting? So a proposer? And a seconder? Thank you. Item 5 is questions from members of the public, and we have no questions from members of the public. Item 6 is questions from councillors, and we have no questions from councillors. So item 7 is the main agenda. On this occasion, I'm going to rearrange the agenda order slightly in order to take item 9, which is the item regarding the Local Government Association offer, which will be presented partly by Zoe Clifford, who is the Director of Public Health, and Steve Bedser, Partner in Care and Health Programme, commissioned by the Local Government Association. Thank you.
Thank you, Chair. I'll keep my introduction quite brief because then over to Steve in terms of the offer of support. So this comes out of our last conversation at the board in terms of the desire to refresh the health and wellbeing strategy, but since then there's obviously been lots of other moving parts in the system in terms of the need for us to have a neighbourhood health plan, the need for us to have a 5-year plan, all of which needs to happen by April time. So all of that, I think, gives us a good opportunity to review where we are as a board and how we function as a board, and to get that right first before we move on to developing those plans, and then to refreshing later on in the year our health and wellbeing strategy. So I've approached the Local Government Association to look at what support that they could offer, because certainly got that experience in terms of working with other health and wellbeing boards. And I will hand you on that note then over to Steve, who will take us through what the proposal is.
Thank you, Zoe, and thank you everybody for inviting me to come and speak to you today. So my name is Steve Bedser, and I work as a contractor with the Partners in Care and Health team, who as one of their functions, deliver support to health and wellbeing boards up and down the country. It's a programme of work that's funded by the Department of Health and Social Care and is delivered on their behalf through the Local Government Association. It's important to highlight that there is no cost to the host organisation for accepting the support offer from us, other than the opportunity cost of your time and commitment to the process. So this is a resource that's nationally funded in recognition that health and wellbeing boards are extremely important parts of the system, the wider health and social care landscape. And there is an intent on the part of this government and previous governments to make sure that they operate in as optimum fashion as possible. Zoe has been in touch with my national colleagues to scope the potential for the support that we might offer you, and that's translated into me coming along today and very likely being the person that will be part of the team that would be offered to you, alongside a colleague called Joe Webster. We're a really complementary double act. My background is in public health and senior primary care management, spiced up with some experience as an elected member, where I was the cabinet member for health and wellbeing in Birmingham and the chair of the Health and Wellbeing Board in Birmingham a long time ago. And Joe Webster comes as a very experienced NHS leader, having been an accountable officer in CCG territory, but she's also had some joint posts between health and local government. So between us, I think we're placed to offer you a wide perspective, also borrowing from the now extensive body of knowledge that we have about what works, what doesn't work, and what makes for an effective health and wellbeing board. And we're happy to be given the opportunity to share that knowledge and understanding with you. We always make a commitment to making the work that we do tailored to the local place. So were you to want this offer of support, we would set about to have some one-to-one conversations with a representative sample of stakeholders. We haven't got the resource to speak to every single person, and actually, given that one of the dates that we're aiming for is the 12th of January, I don't think we've got the calendar days to have those one, but a representative cross sample, so that we can rapidly build a rich understanding of where you are in Herefordshire, what your relative strengths are and what your relative weaknesses are, to enable us then to put that back to you through the lens of what we know works, and then help you in a workshop style setting think about the things that you need to cherish and hold on to, and then think about the things that you need to change with purpose for the future. Whenever anybody attends a workshop that I facilitate and Joe facilitates, we're always very oriented around action. We're happy to have a warm and comfortable conversation to begin with, but we will then want to translate that into a meaningful conversation with bite that then results in a set of actions that everybody's clear about, and a plan to do things that will do things differently and better going forward. And then we would work with you to support you during the rest of the municipal year to see what additional support you might need. I should say that if we were having this conversation 12 months ago, our focus would be very much around what are your priorities that will help you reduce health inequality by driving hard on the wider determinants of health. And those local priorities have varied according to place. I should say that in the last 6 months, there's been an increasing focus on neighbourhood health as being something that the Health and Wellbeing Board has chosen to rally around and to raise its game in terms of using neighbourhood health as an opportunity to make enduring and important difference. And without wanting to prejudge the one-to-one conversations that we would have if you wanted to engage our support, I'm quite certain that we will be helping you with some of the critical conversations that are going to take place in the first quarter of next year in terms of getting neighbourhood health right for Herefordshire. I'll stop there. I can speak endlessly about this support and about health and wellbeing boards, but I'd much rather hear if there are any questions or points of clarification, and then allow you to make a decision about whether or not you'd like to take up the offer.
Thank you, Steve. And firstly, may I thank you so much for coming to see us face to face, because that, I think, is really important. And I do appreciate that isn't necessarily an easy task for you. Does anybody in the room will have any questions they would like to ask? David?
It's not a question, it's just to support the offer. I think I've been on the board for a couple of years now. I think with the advent of the Neighbourhood Health guidance coming out and the clarity of the role from health and wellbeing boards, I think it's really good timing just to think about what the next iteration of the health and wellbeing board is. So I fully support having a bit of external facilitation to take us through that.
Anybody else? Hilary?
Just to echo David's point, welcome the review, welcome our opportunity to reflect and set ourselves up for the future.
I mean, I think it's almost as if we knew you were coming because we talked previously about looking again at the Health and Wellbeing Board strategy, Health and Wellbeing strategy, because having had a CQC fairly recently, although it seems a long time ago and we haven't had the result yet, I read the Health and Wellbeing strategy on a number of occasions, and I began to realise that actually it was, although it wasn't that old, it was started in 2021, it was out of date, well out of date. Things in health and care, they change so rapidly that it was definitely due for a refresh. So I think this is an ideal opportunity that you're offering us to do that. So I'm really grateful. Anybody else have any comments to make? No? Right, so the recommendations are that the Health and Wellbeing Board agree to the offer of support from the Local Government Association to review ways of working in preparation for the Health and Wellbeing Strategy refresh later in 2026. Do I have a proposer? Seconder? All those in favour? Any against? No. Fine. Thank you so much. Yeah, you can speak. Yeah, absolutely.
So, thank you, Chair. I'd like to draw your attention to the fact that you have a to-be-confirmed date on the 12th of January for the workshop that we're proposing. From our perspective, that's entirely achievable, and I think in terms of the pace at which you need to work, particularly around neighbourhood health, a very timely opportunity. So if you're able to commit to the 12th of January as the date of that workshop, we are able to facilitate. But what it does mean is that we will need some extra discipline and cooperation with diaries so that we can get one-to-one calls in very early January. So I've just asked you, Zoe has already indicated that we'll get some local admin support to set those calls up. But if you could make sure that the people managing your diaries know to expect them and to prioritise them, we'd greatly appreciate it.
Absolutely. Thank you. And thank you for coming along. And safe journey home. So we now move on to the order of the original agenda. So item 7 is Tackling Domestic Abuse Strategy Update. And I'd just like to comment on this, that when this came to full council, it was titled the Domestic Abuse Strategy, and one of the councillors pointed out to us that it made it sound as though what we were doing was dealing with domestic abuse once it had happened. And so we took that on board, as I would always do, and we've now called it Tackling Domestic Abuse Strategy. So it covers both trying to stop and tackle people with domestic abuse and deal with it after it has happened. So I now move on to Kate Thompson-Dixon to present the report. Thank you, Kate.
Thank you, Chair. I have pressed the button, but nothing's happening, Ben. Thank you. Apologies for that delay. And thank you for the introduction, Councillor Andy. This strategy was published earlier this year in July, and yes, following the full council meeting in October, we have updated the title. So the strategy is being developed by the Domestic Abuse Local Partnership Board. That is a statutory requirement for us to have that board as a local authority, and it is made up of multiple organisations who are working together to improve the outcomes both for people experiencing domestic abuse and to prevent domestic abuse from taking place. Part of the board's function is to look at our knowledge and intelligence, identify gaps, and then produce a strategy to address those. As most of you will be aware, domestic abuse has a huge impact on the lives of people that experience it. And the board, when it was first set up in 2021, also commissioned a lived experience advisory network that supports individuals who have experienced domestic abuse to assist us in developing our policy and practice. And although our strategy does acknowledge the gendered nature of domestic abuse, it also seeks to ensure that the response locally is accessible to everybody regardless of their gender or other protected characteristics. The vision for the strategy for Herefordshire is that we become a county where domestic abuse is not tolerated, that everybody can live free from abuse and harm, and those people who have experienced domestic abuse, including children, have access to the right support at the right time. This is the definition of domestic abuse as defined in the Act of 2021, which, as you can see, defines domestic abuse as abusive behaviour between individuals aged 16 or over and who are personally connected. But the Act in 2021 also extended to acknowledge that children are victims in their own right. So it's important for us to point that out. Okay, so in order to put together the strategy, we carried out a needs assessment in 2024. That estimated that around 8,000 people a year in Herefordshire experience domestic abuse, and the majority of that 8,000 being women. During the year prior to that, Safe Lives conducted an independent review of the domestic abuse system in Herefordshire, and we used both of those, those Safe Lives review and the needs assessment to inform the strategy work. And as I've already mentioned, the Lived Experience Advisory Network was also consulted. Their feedback played a large part in developing the strategy as well. These are just a couple of quotes from people who have experienced domestic abuse who helped us to develop the strategy. There are many, many more, but this is just a quick snapshot of things that remain a major concern. So you'll see here reference to the stigma attached to domestic abuse and shame, worrying about being believed, having a hard time with people who don't understand the choices that you may have made, having difficulty moving forward and away from perpetrators if you have children together. A quote here that is obviously from a child who has experienced domestic abuse about school being safer than home. And the one centrally there is about victims being asked to repeat their stories over and over again, which as a system, and certainly as a local partnership board we have acknowledged, is really problematic for individuals, and we must work harder to identify ways to stop that from happening and to make it easier for people to access support without having to retell their story over and over again. The strategy itself has 4 main priorities, and these capture both, as we've said earlier, that the strategy is about tackling domestic abuse that has taken place and also improving prevention of it, as well as the prevention is around improving awareness, putting in place early identification and support, educating our young people and raising awareness around healthy relationships. Our second priority is about improving the understanding of domestic abuse and support services, looking at training, challenging some of the long-held attitudes and beliefs when working with people who have experienced domestic abuse, and developing and building on our understanding of the impact specifically on children and on older people. Thirdly, there is a priority to improve joint working and coordination across services. And fourthly, to hold perpetrators to account for their behaviour. Because the strategy has been developed by the local partnership board and we do have policing partners on that board, so we're able to really get to grips with the actions in regards to perpetrators as well. The next 2 slides just comment on the links of the tackling domestic abuse strategy with the Health and Wellbeing Board priorities. So the first one being Best Start in Life for Children. And this just lists 6 ways in which the 2 strategies are linked. As I've already mentioned, children are recognised as victims in their own right in the 2021 Act. And we know that children who witness or experience domestic abuse face significant risks to their psychological, physical and emotional and cognitive development. We want, obviously, those children to grow up in safe environments, so very clearly linked to the priorities of this board. There's some other links here around safeguarding and protection and supporting parental well-being, helping people to escape abusive situations, and support their mental health and stability. So there's a crossover there with both Best Start in Life and good mental well-being. If we could move to the next slide. Thank you. I think I've managed to share it myself now, thanks Ben. It started working. So here there are some other links to that good mental well-being throughout life. So there are crossovers with reducing trauma and psychological harm, supporting recovery and resilience, breaking cycles of abuse, and promoting healthy relationships, and of course multi-agency coordination in terms of timely access to mental health services for people affected by domestic abuse. Those are the ways in which the strategy links to health and wellbeing priorities. The strategy also links across to various other priorities as well, particularly those focused on vulnerability and addressing complex needs, our housing and homelessness prevention strategy, and a strategy that's currently in development, which is around complex lives. In terms of governance and measuring, the Domestic Abuse Local Partnership Board meet quarterly and review the delivery plan that has recently been put together and launched with partners, and that enables us to measure progress against those priority outcomes as a group. And I'm very happy to take any questions.
Thank you, Kate. Anybody got any questions? Steve?
Taking the prevention theme, in the report there was the DRIVE programme and the Men and Masculinities programme. In terms of how effective have they been in reducing, I guess, repeat offending?
Those two programmes are commissioned by the Police and Crime Commissioner, so they take the direct measurement of the effectiveness of the programmes and report into the Partnership Board. There has been there's a lot of good evidence for the DRIVE programme in particular, so I believe that those have been relatively successful. I don't have the data to hand specifically to show the number of outcomes, but we would be able to provide that to the board if that's helpful.
Is it possible, Kate, that you could just explain to those who don't know what the DRIVE programme is?
Yes, sorry. The DRIVE programme is for high-risk perpetrators who are referred in, usually by the police, to a behaviour change programme. The Men and Masculinities programme is similar, but for lower level risks.
Thank you. David?
Sorry, I didn't mean to go first. Couple of things for me, really. I mean, you talked about the importance of listening to people with lived experience. Can you just tell us a little bit more about what you've done to date to get that lived experience and what we plan to do going forward? Because I think it's really critical part of development of any strategy for us to genuinely understand what people are feeling and what they need.
Yeah, absolutely, I agree. It's really important for us to get this right, and it's not necessarily a straightforward path either to get that completely right. We established the Lived Experience Advisory Network, and that has been our primary method of engaging with people with lived experience. That's coordinated by West Mercia Women's Aid, and it's a joint project with Worcestershire County Council, so we have a number of different voices represented in that network. So they have commented on seeing our needs assessment, the Safe Lives review, the development of the strategy, and then they are represented at the local partnership board each quarter, so they're able to bring representation of the group to the board to comment on agenda items and the further development of the delivery plan and practice going forward.
That's my second question. So the other thing that occurs to me is that collectively we're the biggest employer in the county, you know, the trust, the council, ICB, police, the public sector as a whole. What can we do as employers to make it easier for people who work for us to come forward and seek help through work?
Thank you. I think there's a couple of things that I would suggest. One is slightly aside from your question in terms of the training and development for operational staff. That is really critical and is a really large part of our delivery plan, is ensuring that all of our frontline staff have awareness training. But in terms of us being employers, we have recently been members of the White Ribbon Network, so that has been a mechanism that we've used as a council to be promoting accessing support. I think there are a multitude of ways that you could achieve that as an individual organisation, but I guess the things that we are typically promoting through the local partnership board are reducing that stigma and shame. And the more we talk about domestic abuse, the more we raise awareness about what it is, what it involves, and that there is no shame in asking for support and help. The more avenues we create for asking for support. So recently we have funded, alongside our ICB colleagues, the IRIS programme in GP practices. That has been specific training for both GPs and practice staff over the last 2 years. In the year prior to the IRIS programme being in place, so 23-24, there were 2 referrals from GP practices into West Mercia Women's Aid in the 2 years since the IRIS programme's been running, there has been more than 100 referrals. Some of those were also for men. So I think developing more and more pathways into support services and earlier is probably the best thing that we could be doing as employers.
Before I come to Sarah, could I just explain for people who are listening what the IRIS programme is?
Yes, Chair. The IRIS programme is a training programme essentially for GPs and for practice staff in the early identification of domestic abuse, so early warning signs and concerns, and about identifying them, and then how to have those difficult conversations with individuals and recommend appropriate support.
And am I correct in believing that we are not confident that that will be continuing?
That's right. So the funding will come to an end for that programme specifically at the end of March, although West Mercia Women's Aid, who run the programme, are seeking alternative funding sources. The programme also does need to develop a little bit, so it's been very much focused on training for health professionals. They have done some training in the hospitals staff as well. But going forward, it will be about how we continue that momentum really. The programme itself of training doesn't necessarily need to continue in its exact current form, but it would, we'll be looking at how we can continue the learning from the programme.
Thank you. Sarah?
Just in relation to, you mentioned children and young people who have either experienced or witnessed domestic abuse. Are we proactively within the planning to support those individuals, or are we kind of reactive, waiting for the young person or child to start to display symptoms? How interlinked are we with children's services?
So Children's Services are represented on the local partnership board and have been part of developing the delivery plan. So in the delivery plan, each agency has their own subsection of actions. Some of those cross over multiple agencies, but Children's Services have developed with us their specific actions. In terms of how proactive we are being, again, that has been very much focused on raising awareness. We're holding an event early next year, which is to support teachers, particularly Key Stage 2 and Key Stage 3 teachers, around healthy connections, promotion of healthy relationships, how to access support services, early warning signs, and again around that early identification and prevention. So we're trying to work as proactively as possible across the full spectrum of partners. So yes, with Children's Services, also with our education colleagues, and again in the examples like the IRIS programme, which has been primarily targeted at identifying domestic abuse in adults, but isn't limited to that. It could be identifying domestic abuse in children as well. Physical symptoms, as many of you may well be aware of in children, often are anxiety, tummy pains, unexplained stomach issues very often are an indicator of a broader problem at home or at school. So that kind of programme supports the identification in children as well.
Sorry.
I was just going to pick up on David's point around the anchor institutions, anchor organisations, because I think actually at the moment, so as Katie said, we've been white ribbon accredited before. I've had a conversation this morning with one of your colleagues, David, in terms of ICB approach to domestic abuse, and I think that's where actually there's real value in terms of us as a board and the organisations that we represent, that actually what are the core components that we want, so that we do it once across all of the organisations, as opposed to all doing a slightly different take on it, and that we have that more coordinated effort that we can take back through the Health and Wellbeing Board, but certainly through Domestic Abuse Partnership Board as well.
Oh, Jo.
Thank you. Just got a couple of comments and questions, if that's okay. So as someone with lived experience of domestic abuse, and currently my daughter is in a relationship that is where she's on the receiving end of domestic abuse. A couple of things that I've sort of found recently is that we need to ensure that the police are actually holding perpetrators to account. We need to make sure that it's not just about sort of the training for health or the training for police. It's about the training, the recognition, and then the following it through. I think it should be mandatory training, to be honest, particularly for police. There's something also about thresholds for me, with both with CPS and with social care, from a prevention perspective. Having seen myself with my daughter, how because she doesn't quite fit thresholds, you know, she hasn't really got the help. And I would like to have a chat outside of the meeting about potential neighbourhood health approach, where we're looking at, you know, how can we sort of make this everybody's business with our, when we're thinking about developing neighbourhood health.
Thank you. Absolutely, fully agree. Training, it would be ideal if it was mandated across organisations. I think part of tackling domestic abuse and getting to the root cause of it is really challenging those stereotypes that we have. It's challenging the threshold of what we think is bad enough, what we think domestic abuse is, and accepting that it takes many different forms, and if it is affecting somebody, then there is something we should be doing as a system about it. So yeah, fully agree with your comments, and very happy to meet separately to discuss the neighbourhood health approach.
No. Can I just ask, in amongst all of this, there is a lot about men and women, but there's nothing about, or very little about domestic abuse of boys, generally, boys or young men on mothers or on fathers. And I just wonder how prevalent that is and what we're doing about that.
Thank you, Councillor. Yeah, there is a lack of information about that, partly because we have very little data, if any, to support what the local picture is. So it has been challenging to include any specific information within the strategy in terms of what that looks like locally. Throughout the needs assessment, which is a really big document, I don't expect everybody to read cover to cover, but you can see the challenges in data capture throughout that needs assessment. There's a lot of missing pieces of the puzzle, and part of the delivery plan is to improve that data capture across the multiple organisations, so that we can build up a better picture of exactly what is happening to who and how frequently within this county, and that obviously will help us redefine our priorities year on year and ensure that they are the right ones.
And the other point I was going to make, you've got a list of recommendations here, quite a long list of recommendations actually, and I was pleased to see that you are having an increased focus on capturing the demographic composition features of perpetrators of domestic abuse in the future, and this could then be used to inform and target prevention efforts, because I think we do a lot of work. We do work on people who are victims of domestic abuse. What we need to try to do is to find out why people feel it is okay to abuse a partner or a parent or whatever, and I don't think we've got enough information about why that is.
Yeah, absolutely. There are real gaps in the data. So to date, there hasn't been any collection, I believe, of demographic data around perpetrators. So it's just been number of perpetrators and whether they are adults or children. So it obviously increasing, as you said, increasing the knowledge around that demographic data will help us to tailor support services, preventative activities, inform things like the DRIVE programme, male and masculinities programme, ensure that those are targeting people appropriately.
Thank you. Jonathan.
Yeah, thank you, Kate. Do we know how registered landlords deal with this issue, and whether there's a support network there for some of the housing providers who house quite a few people?
Yeah, absolutely. So we work with a lot of our registered providers to provide emergency accommodation. So that is when people present as homeless, fleeing domestic abuse, to our housing services. Most of those housing providers have their own specialist domestic abuse workers embedded in the service, and at least one of them has that service embedded because we specifically commission them to. So the definition of safe accommodation, which we are required to provide from the government, includes accommodation with support. So it can't just be premises alone.
Steve?
I just wonder if you could bring to life a little bit of West Mercia Women's Aid in terms of their role, because they're the local charity and I guess integral to or their input into the strategy and its delivery.
Yeah, absolutely. A really key stakeholder. West Mercia Women's Aid are commissioned by us as a local authority to deliver support services. That includes a helpline, refuge, one-to-one and group support. They also deliver a number of educational programmes within schools, both directly with pupils and with teaching staff. They are a really enthusiastic and proactive charity, so outside of what we specifically commission them to do, they do a number of other projects and deliver as much as they possibly can, essentially, to women affected by domestic abuse and children. Men who have experienced domestic abuse are referred to another organisation called Cranston.
Yes.
I just wanted to come in on the point about child and adolescents violence towards parents. So across children's, every member of staff has been sent a briefing paper to support them to identify if that is an issue in a family. There are 4 workshops in the new year, online workshops for all staff to attend, and then there are 2 half-day training courses on that very topic. So I just wanted to reassure
Thank you.
that that's...
Thank you.
Yeah.
Anything else? Just one other comment I wanted to make. The Men and Masculinity programme, over half, well, no, just under half, don't complete the course. Do we know why that is? And do they leave the course after just one session, or is it towards the end?
I don't know the specifics about the reasons for disengagement, but I can get those and report them back.
It'd be really helpful to know, because if it's at the very beginning, it's about, for me, how is it introduced? How does it start? Does it put people off the first moment they arrive? If it's towards the end, do we do anything to try to keep people on board or not?
My understanding is that the service does do a lot of work to keep people engaged, and I imagine there'll be a plethora of reasons why some people disengage from that programme. Some might be because they receive a custodial sentence right way through, but we can get the data and share it with the board. That's
Thank you.
No problem.
Thank you. Anybody else? Right, Ed, I'm going to let you speak. I wouldn't normally, but I will, on this occasion, I will let you speak. As long as it's short.
Thank you for your indulgence, Chair. It was just, I was curious to see the one of the things you said was housing sanctions for perpetrators as one of the things you're looking at exploring, and housing is something I'm very involved in. I was curious to know what kind of ideas you're exploring around that, and how that's worked in practice potentially in other counties.
So the basic premise for why that has been included is because there is understandably a desire to keep victims, and particularly victims and children, in their own homes, and that has been really significant feedback over the last few years. Most often victims have to leave. They have to leave their home and their possessions, their pets, and that has been the general course of things for many years, and understandably that isn't necessarily appropriate, or it's very, very disruptive for families. So the housing element has been around how can we support victims to stay in their own homes, and what are the variety of measures that we could use to enable that. And we're working closely with our housing, strategic housing colleagues to explore all of the various different ways in which we can enable that.
Anybody else got any questions? I think it's a very good report. I have to say, it's a very detailed report. It's a good report, and you know, I think it's one of the best reports we've had on domestic abuse that I've seen. The recommendations are on page 10 in my document, but on the front page. So the board received and note the response to domestic abuse within Herefordshire, and the board is asked to make any recommendations or suggestions in connection to the report, which we've done. Have we picked up any recommendations?
Not as such, no, but just an action in terms of circulation of that data regarding non-completion of courses.
Right, thank you. So, do I have a proposer that we approve the report? Henry, seconded. Jonathan? Okay, thank you. We now move on to item... Sorry, I've gone too far now. Item 8, which is the Neighbourhood Health update. And the presenters of this will be Joe Hodgetts, who is the Associate Director of Neighbourhood Health, One Herefordshire Partnership, and David Collier, who will tell us about how we can, this new approach drive prevention, and he is the consultant in public health and also a general practitioner. So do we start with Joe? Thank you.
Thank you. So you've obviously got the paper that's been circulated already. So there's just a couple of key points that I wanted to pull out and highlight today. So this was written from a draft document, so draft National Neighbourhood Health Framework, which we were expecting to have been circulated already. In usual fashion, we're still waiting, but we are very close to national colleagues that are drafting this, so we're confident that it shouldn't be changed too much. So what I wanted to do was make you aware of the new requirements. We've covered those a little bit this morning when Steve was talking earlier about working with the Health and Wellbeing Board. So the Health and Wellbeing Board will have a much sort of larger part to play within Neighbourhood Health from a strategic position. And the Health and Wellbeing Board will be required to produce an interim strategic neighbourhood health plan by April 26, which will soon be here, won't it? And then support an underpinning interim operational plan by September 2026. So you'll see in the paper that there are some recommendations for how we approach this. I think it's important to note some of the key things that need to be in the plan. Some of it we've talked about in other forums and in health and wellbeing before. So it really needs to be based on what the population needs. So we've talked about JSNAs, etc., and how we are really data and evidence driven. Ensure we understand the wider partnership working that's needed to obtain the maximum benefit for the full range of services. So there's something here about ensuring that we're needs driven and that we start with those priority needs rather than trying to do everything all at once. So we're required to define the neighbourhood footprints within the strategic plan, set shared vision and priority outcomes for both place and neighbourhoods, set out the components of the neighbourhood health service that are most relevant, so again working on those priority sort of cohorts. This is one of the biggest changes from the guidance last year, which is including plans to establish integrated neighbourhood teams on a contractual footing. So I think the learning from what we've seen so far, rather than sort of just expecting people to work together, is now becoming more formalised with bringing in a contractual footing, and to organise leadership and accountability arrangements at place in the form of provider partnerships. And then the operational health plan is essentially how we're then obviously going to deliver that strategic plan. There are some interesting points in the requirements for this. For example, conducting an audit of resources and capabilities across all partners in each neighbourhood and those available to support at place and ICS level. So I think for me that's something about acknowledging that there isn't a load of new resource, new cash. This is about making sure that we've got the people that we already have, the assets that we already have, organised in the right way to meet the local population's needs. Point 10 also includes the ambition for a neighbourhood health centre in every community. So the neighbourhood health centre archetype is still under development nationally. Again, we expect that to be published in around January, and that archetype will really help us to discuss, help our local discussion around our current assets and the future of things such as minor injury units versus neighbourhood health centres. There's also in the new guidance a suggestion that there'll be a Better Care Fund reform and some information and guidance to us that describes how to go about that. So I'll come back in a minute to what we've done so far and just take you to point 18, which is around the One Herefordshire partnership approach to governance to support all of this. So we've been working as One Herefordshire partnership pretty much since Sarah came into post to look at the refresh of governance, and we have 2 terms of reference for 2 boards. One is the Health and Care Partnership Board, which is really about that partnership formality, a place for delegation from the ICB for monitoring contracts and stuff like that. And then the One Herefordshire Neighbourhood Health Delivery Board, which is, as it says on the tin, about delivery of the strategic plan that will be led by the Health and Wellbeing Board. So we're hoping that those terms of reference will be approved this week by One Herefordshire Partnership board members, and we are asking for support from the board today in terms of that wider governance structure. Should I just continue with my other 2 points?
Yeah.
So just staying with the developing the plans for Herefordshire. So myself and Zoe and other members of 1H have talked about approaching with some task and finish groups with key members of the Health and Wellbeing Board to develop the strategic plan. With the support of our national coach in terms of the facilitation. I think it's really helpful hearing from Steve today from the Local Government Association. I'm sure that we can work together to make the best out of how that would work. Then the group would obviously each agree their key individual responsibilities for the contribution to the sort of narrative and plan on the page, and then we'd have an engagement process with key stakeholders, noting that as well as the Health and Wellbeing Board strategy refresh, we'll do an interim sort of overall neighbourhood health strategic plan and follow up with the refresh with that timeline. And just going to take you back to where we are so far with the delivery of neighbourhood health, she says, if I can find it. So it's around point 12. So we came and described in the last meeting how we had, I think we'd just been notified, hadn't we, that we're part of the National Neighbourhood Health implementation programme, one of 43 sites, and I think it's fair to say it's been full on, hasn't it? It's been really, really full on, hands on, sleeves rolled up by all participants, and we've had really good engagement across sectors. So we've gone from, I think originally there was about 30 stakeholders in our community collaborative. We're now up to 90. So it's growing, it's evolving as we go. We are at the moment working to operationalising our first integrated neighbourhood team within January, based around a priority cohort, and it is priority from a health perspective because that's the national direction. But we, alongside that, we're also doing a lot towards the wider prevention, wider prevention, and making sure that we're looking at that outer circle of the neighbourhood health diagram at the same time, which I'm sure David will fill you in more of in a minute. Yeah, I think that's all from me, unless there's any questions.
Well, it's not a question that you can answer, but it's a statement really. The plan appears to be something that has been thought up for urban areas and not for rural areas. And I think we all recognise that from day one. And I think when we had the visit from from Sir Chris Whitty on Friday, he also recognised the fact, it wasn't on Friday, was it? Yeah, it was on Friday, yeah. I think he recognised the fact that having taken him around a part of Herefordshire, that we were not really what you would see as the type of neighbourhood health programme that they had set out. And he actually did make some comments about the fact that it's got to be more flexible. And one of the things that I picked out in here that I thought that isn't going to happen is define neighbourhood footprints at approximately 30 to 50,000 people. Well, that may cover Hereford, but what happens to the rest of us? And so I think however way we go forward, we have got to be really flexible here, because otherwise we're not going to gain anything other than what we've got now, which is a health service that is difficult for people to get to due to public transport links, and doesn't make any improvements on what we've got at the present moment. And my understanding, money is not coming with this other than for technology. So we're having to implement this, but we haven't actually been given money to do so, which is not unusual from governments, but it's very disappointing, I think.
Yeah, agree. And I suppose one of the benefits that we've been on the national programme, is we are feeding back regularly, and we've got a really good relationship with the national team, with Manal. Manal came to visit on Thursday, and sort of saw firsthand some of those challenges and differences. We're also, with being on the national programme and the other 43 sites, it also enables us to work with other people like Cornwall. So their approach in Cornwall has absolutely doesn't fit the sort of standard, like as you say, what's described. And we've already been speaking to them about their community health and wellbeing worker programme, for example, and how they've sort of almost gone against the grain because they've had to be in rural, and what they've learnt from that. So I think we're in a position where we can learn from others, and Manal was really clear in her, you have the agency to do things differently and make it work for Herefordshire as being part of the national programme, so we'll definitely take advantage of that.
Thank you. Jonathan.
Yes, thank you, Chair. Yeah, referring to it as neighbourhood health plans just really shows the mindset of those involved, which is very urban-centric in their thinking. I think we've got to be inventive ourselves, and we've got to come up with a better phrase than neighbourhood, because in my experience in Herefordshire, we deal with localities, don't we, not neighbourhoods, and those localities encapsulate not only just the neighbourhood of a market town or something, but a rural hinterland as well, where members of the public are drawn into certain localities. And so perhaps in our thinking, we could think about the geography and the nature of the organisations that already exist to build that strategy around those. And so I think this would be probably more locality working. It'd be interesting, Joe, to hear how Cornwall have dealt with that, whether they've used the locality approach. But I think we just need to be making sure that we don't lose the spirit of the initiative, but we want to tailor-make it for Herefordshire so that it's appropriate for us.
Thank you. And as someone that represents probably the most rural county ward in the county, so my ward is 60 square miles, getting even into Leominster is a struggle. if you don't have a car, or if you've only got one car and the car is being used by somebody who's using it for work or taking children to school, whatever. So I think we need to look at the flexibility about, taking it out to people that can't get to us. And so it's a mixture of the two, really. A lot of my residents don't recognise the market town as being anything to do with them. They make their own ways in the way they can, and I think that's what we've got to do. Zoe?
Yeah, I totally agree. I think this is an opportunity, isn't it, for us to do what's right for our communities. And I agree in terms of that locality, that community approach. When you talk about what's in the guidance in terms of, and it is guidance around the numbers, that doesn't necessarily feel like that fits for us in Herefordshire. Now, we've got a really good understanding of our population, of what we've got in place, but also what the needs are, but also the differences of those populations as well. What really shone through the Chief Medical Officer day on Friday, where he came to visit, we took him to Ledbury to show him what was in place in Ledbury and all of the assets there. And there was a real strong sense of community, and we can build on that. But also the conversation went into the differences between, actually, that's not lift and shift what's there and put it in Leinster or Bromyard. Because actually there's really different communities with different needs. Now, we understand that. This is an ideal opportunity for us to build on what we've already got in place. And I do think part of that is understanding, how do we connect services better? How do we prevent people from needing the services, but when they do need them, how do we make it really easy for our communities as well? And that might be a digital offer, but it might be lots of other solutions as well. And I think it's an opportunity for us to think creatively. And certainly from Manel's visit from the national team on Thursday, I thought what was really positive about that was it gave us permission to try to work differently, to try to do things differently. I think she came up with 2 rules. One was don't break the law. The other one, can't remember, Jo. Don't make it worse, yeah. I thought actually that was good. 2 really simple rules: don't make it worse, don't break the law, but basically permission to take some risks, try things differently, but build on what we've already got in place.
So, David, do you want to... Anybody else got any questions? Oh, Steve.
Just to say thank you to Joe and colleagues for bringing the VCSE sector in at the beginning of the conversation rather than just an afterthought. 3 or 4 of us have been in there since the first conversation, and it's really good to be part of the solution rather than just delivering the outcomes. Being able to be part of the co-design, co-production is just incredibly refreshing, so thank you.
And I think, if I bring Joe in, I think one of the things that Chris Whitty noted on Friday was, he said, we may have huge challenges in Herefordshire, and we do have, but actually we have huge benefits because we are rural, because we are as we are. We have a lot of community spirit, a lot of working together in communities, a lot of people who volunteer and give their time in communities, working well together. And he met a lot of those community groups on Friday and was really impressed with that, and said, if I went, I won't name the town, but if I went further down the road, that would not be the case. And so he said, you've got big challenges and we need to address those. They need to be addressed, but you've got to also appreciate that you are very lucky in the fact that your areas have got good community spirit and people work really well together.
I think that's absolutely right, but there is a resource implication for the voluntary sector as well.
Yes.
That they can't deliver the aspirations on good wishes and best intentions.
I understand that.
So there is a resource implication there as well.
Sarah?
Yeah, I think there is so much that the national team want to learn from us, and they are really keen at the national events and the national workshops around the community spirit here. but also it's the strong partnership working and the embedded relationships, which is really palpable when you do, you know, walk around and you do, you know, you speak to people from different agencies. There is one goal, one vision, and everyone can articulate that. That isn't the case across the other systems that are actually taking part in the programme. So there's real stuff to celebrate here, and we are feeding in the, you know, the differences from being in a rural county as to urban to help shape the agenda moving forwards.
Joe.
Just to comment on what Steve said earlier, and perhaps we can bring it back at a different, you know, at a future health and wellbeing board. But one of the absolutely brilliant things about this programme is it enables us to get out and about and sort of see what's going on out there. And having started spending time with voluntary sector colleagues, it's incredible the things that they're delivering, that someone who's worked in the health sector for 20 years absolutely just no idea that it's happening. And we're all so heads down, I suppose, with the day job, that actually when you get the opportunity to get your head up and go out and about, and that's what's going to make the difference, is building the relationships, walking in each other's shoes, understanding and building trust about what else is out there to support people, rather than just thinking that, you know, we know best from a statutory perspective, so to speak. So no, it's really eye-opening, and I think it's going to be a really good couple of months getting to develop more of the INT working.
So before we go into a general discussion about this, I'm bringing in David, if you'd like to give us out your views on how this new approach can drive prevention.
Perfect. Thank you very much, Chair. So, yes, I'm going to talk just briefly about how we can use neighbourhood health to drive prevention. How can we use neighbourhood health to stop people getting sick in the first place? Because if we do that, our job's done. So, hold on 1 second. So why prevention? I feel a little bit, coming to Health and Wellbeing Board and talking to you about the benefits of prevention, I feel a little bit, I'm preaching to the choir here. There will be no singing, do not worry. But I think intuitively most people understand the value of prevention, don't they? They understand that prevention's better than cure, a stitch in time saves 9. It's that idea, it's the reason that people go and have a flu vaccination, or they go and get screened for something, or they wear a seatbelt, or they eat celery. All of these things we do because we understand the benefit of prevention. And we can make clever arguments around ethics and social justice. We can talk about economics and return on investment. We can certainly point to lots of policy, can't we? Decades of government health policy extolling the virtues of prevention. And of course, this is nothing new either, which is the quotes I've given you here. We've got at least 2 millennia worth of people talking about trying to move us further towards prevention. So I guess the big question you might ask is, well, why are we still talking about prevention 2,000 years later? And why should neighbourhood health be any different? I think one thing just to put out there at the start, of course, as Joe was mentioning, is that a lot of the initial energy in this space is around that priority cohort. It's around the really pointy end of this. And that's not to say, obviously, in that sphere, there's also room for prevention, and we will talk about that. But I think this presentation really is just an entreaty for everybody to think as broadly as possible about prevention and what that might look like with neighbourhood health. So I just wanted to give you one example. There's millions of examples, but I really like this one because I think it illustrates the power of prevention really well. So I like this because, so this is the idea that if you invest £1 now and giving people warm, dry homes that aren't full of mould, then actually 10 years later you save the NHS £70. And I like this example because first of all it stops you in your tracks with that eye-watering number. I think very few people wouldn't consider that a good return on investment. I also like this because it speaks to those wider determinants of health, doesn't it? I don't think there can ever have been an aspiring young doctor who sat there in a medical interview and talked about their passion for housing or urban design, and yet actually this stuff really does make a difference to health. And thirdly, I like this example because I think actually it illustrates one of those fundamental obstacles to prevention, doesn't it? Because, and you've probably spotted this already, the NHS reaps the £70 benefit, but they didn't invest the £1 at the beginning. And of course, this is the perennial wrong pockets problem, isn't it? And I wanted to raise this just because I think one of the really important ideas with neighbourhood health, if we want to be serious about prevention, is we have to think about how we work together as a system rather than siloed with our individual earmarked budgets. So that's why prevention. Why cardiovascular disease? I think first and foremost because cardiovascular disease remains an extremely important cause of mortality and morbidity, of death and illness. And I've illustrated that on this slide. This is a slide of two halves. It tells the story in two slightly different ways. I want to draw your attention first of all to the graph on the left. And this shows rates of death from cardiovascular disease from the late 60s till today. And you'll see it's quite a dramatic story this graph tells of rates decreasing markedly over that, 50 years rather, both in men and in women, and the gap between the two narrowing. And there's not one single factor behind that, but we've gone from a space where 1 in 4 in the late 60s, 1 in 2 people in the late 60s were dying from cardiovascular disease, now to a point where it's more like 1 in 4. So it's a huge difference. And every time you see a newspaper or a news program talking about the fact that 1 in 2 or 1 in 3 of us will now face a cancer diagnosis in our lifetime, obviously another way of looking at that would be as a success story of how well we've combated cardiovascular disease, so that now people are able to live long enough to get cancer. I know that's quite a morbid way of looking at it. And this dramatic decrease is because of all sorts of things: changes in lifestyle, the fact we don't smoke so much, earlier recognition and treatment of risk factors like blood pressure, cholesterol, clever surgeries, bypasses, stents, thrombectomies, coronary care units, stroke units. All these things have added together. So does this mean cardiovascular disease is no longer a problem? Unfortunately not. It still remains our leading cause of premature death. And that's what the second half of this slide, the side on the right side of this slide, is all about. So this is an installation that was on London's South Bank. British Heart Foundation put this in place on World Heart Day in September of this year. You can just see St Paul's in the background. And the idea here, as you can see, is that every 3 minutes, so that's the sort of time you might take to make a cup of tea, brush your teeth, put the bins out, every 3 minutes someone dies of cardiovascular disease in this country. So it remains an absolutely huge problem. And the other interesting thing about cardiovascular disease, the other reason for choosing it, is not only does it kill a lot of people, but the burden of cardiovascular disease falls very, very unequally. And we've got really good evidence for this. We know that someone's social background very much influences how likely they are to develop, manage, and survive cardiovascular disease. And the inequalities aren't just about deprivation, not by any means. So we know, for example, that men are twice as likely to die prematurely from cardiovascular disease, but women are more likely to be misdiagnosed, more likely, or less likely rather, to be prescribed appropriate medications. We know that people of South Asian or black ethnicity are more likely to suffer from cardiovascular disease than white groups. We know that people with severe mental illness die a shocking 20 years earlier than the average population, and the single biggest driver of that is cardiovascular disease. So this is a disease that still kills the most, and still kills the most unequally. Some good news though. This is a very preventable disease. Not all diseases are necessarily very preventable, but this is one that is. So we could have picked a number of diseases here. We could have said Alzheimer's or Parkinson's or prostate cancer or multiple sclerosis. None of those are particularly preventable, and yet cardiovascular disease is. And I've highlighted, it's quite an old study, but it was a really seminal work in the Lancet. The Inter-Heart study that looked across 52 countries. It was a worldwide case control study. And they found that right across the world, it was the same 9 modifiable risk factors. So the same 9 things that we can do something about that were responsible for 90% of the cases. And this, of course, means that potentially cardiovascular disease is very preventable. And you'll see different numbers bandied around, but this is a fair estimate. 80% or 4 out of 5 cases could be prevented. And I think if you look at those risk factors there in the yellow box, you won't be surprised by any of them. And this is the interesting thing as well, that for all of these risk factors, we already have widely available, evidence-based, cost-effective interventions. We're not relying on any clever future scientific discoveries. We know what to do. We're good to go. And of course, the other benefit as well is if you look at all of these risk factors, if these aren't just risk factors for cardiovascular disease, these are risk factors for all sorts of other bad things, so dementia, diabetes, liver disease, cancer. And so by treating cardiovascular disease, by preventing cardiovascular disease, we're preventing an awful lot of other disease as well. So this is my neighbourhood. This is, you might recognise this is the beautiful viaduct, 31 brick arches. This is a brilliant bit of Victorian engineering from 1861. It spans the Leaden floodplain in Ledbury. Neighbourhood Health, as Joe was saying, it really asks us to look ever more locally at disease and to understand disease ever more locally and to bring those services to people. And if we're going to do that, we really need, this journey starts, doesn't it, with the data and the intelligence, really understanding what's happening with cardiovascular disease locally. And I'm glad to say that that work has already started. This is something that quite a lot of you have probably seen already. This is some very clever work that my former colleague Ryan Davies did together with our fantastic council intelligence team. And this was looking at cardiovascular disease, the need, not at county level, not at PCN level, but right down to what's called lower super output area. So lower super output areas are those areas of between 1,000 to 3,000 people, so a tiny geography of which we have 116 across our county. And what they did in this analysis, they firstly looked at cardiovascular mortality, the death rates by LSOA, and looked to see which LSOAs had the highest death rates. And then they looked at emergency admissions. So these are people that are being admitted to hospital with strokes, with heart attacks. And again, which LSOAs have the highest levels? And then they put all of this together to come up with this list of hotspots, the areas of our county with the highest death rates and the highest emergency admissions. And there's all sorts of fascinating things you can pull out of this. And in the interest of time and the understanding that not all people get quite as excited about data as we do, I'm not going to expand on all of them. But one very interesting thing here is you might have thought, well, okay, this all looks very clever, but have we just drawn up a list of the most deprived areas? Because we know there's a strong relationship between deprivation and cardiovascular disease. But here's the really interesting thing. If you look at the second column, which is IMD, sure, there are some IMD2 areas there, but this is far from a list of just the most deprived areas. And there's some fascinating speculation around this as to whether maybe rurality is a factor here that's somehow diluting that relationship between deprivation and cardiovascular disease. But ultimately, with any data like this, you can look at it and you can say, well, so what? You've shown me some pretty maps, some clever data, you told a good story, does it make any difference? Well, I'm glad to say to you that this is already making a difference. So, for example, with our NHS health checks, which you'll know are health checks that are available for anyone from the age of 40 to 74, not already on a disease register, and those checks look for those all-important cardiovascular risk factors, the undiagnosed high blood pressure, high cholesterol, pre-diabetes. This year, we've decided for some of those health checks to roll out a targeted version. So a quarter of the health checks are being targeted, and we're trying to make that extra effort to reach those people that we know are likely to have high need, but are less likely to turn up for health checks. And how are we targeting? We're targeting them at these very areas. And this is what I think is really exciting about this work, is we'll get to see whether or not our analysis was on the money. Because if it was on the money, what we should find when we evaluate these health checks is that we are picking up more blood pressure, more high cholesterol than we would have expected. So if you don't hear me talking about this again, you'll know it didn't work. Now, when public health people talk about prevention, two things happen. One is we get very excited, and the second thing is sooner or later we start talking about rivers. And sooner or later we start muttering things about things being too downstream and the need to go upstream. And I thought for this presentation, rather than try and avoid that particular cliche, I thought I would lean into it and I would talk about this in the context of one particular river, which is our beautiful River Wye. So we're going to start as downstream as you can go. So as you may know, the River Wye and the River Severn start only a mile or two apart in the Welsh hills. And then the River Wye winds its lonely way for about 155 miles before it rejoins the Severn here, just south of Chepstow. So this is as downstream as you can get. And I'm using this in my clumsy analogy to represent tertiary prevention. So this is what we do when, in some ways, the worst has already happened. So tertiary prevention is when people already have established disease. So they've had their heart attack, they've had their stroke. But there's still a role for prevention here. But now it's about how do we get them back to their baseline? How do we limit the disability? How do we help them cope with what's happened, stop it progressing further, and maintain their independence. So what might that look like in neighbourhood health? Well, I think the first thing to say, obviously we've talked about, and Joe's talked about this priority cohort. And the priority cohort is people with 4 long-term conditions and 1 emergency admission. So you won't be surprised, after all I've spoken about so far regarding cardiovascular disease, that of course there's a lot of cardiovascular disease in this cohort. There's a lot of people here who have already experienced a heart attack or a stroke. In fact, nearly 70% of them have cardiovascular disease. They're also, by definition, almost going to be complicated patients, aren't they, or more complex patients. And so the things that are going to be really important here are those things that we already know about, the things like the multidisciplinary team that wraps around these people, the comprehensive geriatric assessment, the secret source of GP continuity, medicines optimization, all of those things that we know about but we need to do better. Also, there's things like rehab. We know how important, if you've had a stroke, if you've had a heart attack, how important rehab is to get you back to being fit, to stop you becoming more unwell, to maintain that independence. So what does rehab look like under neighbourhood health? How do we bring that closer to where people live? How do we expand it to more people, more conditions? Is it going to be hospital teams? Is it going to be community groups? Is it going to be the voluntary sector? Is there going to be a digital offer? The other thing I just wanted to raise on this slide was in the bottom right, our prevention in adult social care strategy, which is a very exciting bit of work that we're working on at the moment, and we're hoping to bring to Health and Wellbeing Board in the spring. So this is a sort of teaser trailer for it. But as you can imagine, I mean, a big part of that strategy is thinking about how we help people to maintain their independence, how we prevent their social care needs from escalating. And obviously, it's going to be a big overlap there, isn't there, between that cohort and the cohort we're talking about here in neighbourhood health. And so I think it's going to be really important that those 2 key bits of work align. Okay, so let's go upstream a little bit. So we're now into secondary prevention. This is Ross on Wye, beautiful market town beside the Wye, and also the birthplace of British tourism from the late 18th century when they started to do boat trips down from Ross to Chepstow, which was the first package holiday. And what we mean by secondary prevention, this is about trying to find that disease early, trying to pick it up very early so we can prevent it progressing. And in a sense, this is a bit like a thought experiment, isn't it? This is a bit like taking our priority cohort and saying, well, 5, 10, 15 years ago, what could we have picked up? How could we have treated them then to stop them ending up in our priority cohort? So what does secondary prevention look like? I've already mentioned some of this. I've mentioned the health checks. I mentioned the universal offer, the exciting new targeted offer we're trying. We've had a successful pilot of workplace health checks, which is another way of reaching a group, particularly working age men that we know are less likely to turn up for health checks otherwise. We've got an exciting proposal to apply for British Heart Foundation funding to look at a project around health checks for our farming community. And also OHID are currently piloting online health checks, which might be something on our horizon. We know certainly in the 10-year plan there's lots of talk around analog to digital, isn't there? And this idea that perhaps the NHS app's going to become the front door of the NHS. And you can see, can't you, with wearable technology, there's huge potential for picking up things like blood pressure, arrhythmias, atrial fibrillation on a watch on your wrist. But of course, we also need to be very careful that we don't deepen the digital divide that we already know exists in our county. And of course, when we're talking about picking things up early, we're talking about that extra diagnostic capacity. So under neighbourhood health, where does that need to sit? How do we bring that closer to people? Is it going to be in some kind of neighbourhood health centre? Is there a bigger role for community pharmacies? Okay, and now you've paddled even further upstream. You've got to the very source of the Wye. You cannot go any further upstream. This is on the side of Penlymmon in mid-Wales. Always difficult to show the source of a river on a slide without looking just like a muddy field, but bear with me. So this is what's primary prevention. Primary prevention, of course, is that universal offer, isn't it? It's what we do for everyone to try and prevent them becoming sick in the first place. And the idea is if we do our primary prevention well enough, we need to do a whole lot less secondary and tertiary prevention. So what does that look like in the neighbourhood health space? Well, again, there's loads of great work going on here, whether it's tackling those wider determinants of health, looking at keeping our homes warm or reducing social isolation and loneliness, our healthy lifestyle service, helping people manage their alcohol, their exercise, their diet. And I think this has been alluded to already, but when we were first starting to look at neighbourhood health, particularly when we were doing that expression of interest for the pilot programme, I was really, and with CQC as well, I was really struck how much of this good stuff is already out there, how much stuff we're already doing. And to a large extent, it's not about reinventing the wheel, but it's about finding that glue that binds all of this together. And if we're honest, the offers we have can be confusing, can't they? They can be confusing for the public. If we're really honest, they can be confusing for the professionals. You know, how do we know when a Herefordshire resident needs a healthy lifestyle trainer or a health and wellbeing coach, or maybe they need a social prescriber, or maybe they need a mental health link worker? How do we rationalise this? How do we make this into a more coherent, cohesive, effective offer? And I think that's definitely one of the challenges that faces us. And now finally, there's one intervention I haven't mentioned so far, and very deliberately left it out because I think it's hugely important and I think it deserves a slide of its own. And that's smoking cessation. As this slide shows, it's the drug that kills half its users. I think when you come to talking about tobacco and the damage it causes, you can quite easily run out superlatives, can't you? And you can talk about numbers of death and cases of COPD and costs to the NHS, and you end up with lots and lots of numbers with lots of zeros, and after a while people's eyes glaze over and you realise it's not having the impact you want. I think for me, the most compelling statistic around this is just that if you are a lifelong smoker and you want to know what the future holds, it really is a case of taking a coin out of your pocket and flipping it. And if it's heads, you've got a normal life expectancy. If it's tails, you're going to die prematurely. And they really are the odds for lifelong smokers. And we've made huge strides here. If you remember that graph I showed you a moment ago, that huge decrease in the rates of cardiovascular disease and the deaths from cardiovascular disease, modelling suggests probably around half of that was due to the decline in smoking. And this is really difficult to believe now, but back in the 60s, 70% of men smoked and 40% of women. If they'd had health and wellbeing boards back then, probably half of us would have been sitting here now with a cigarette in our hands. And now that figure's more like 11%, which is a huge decrease. But before we all pat ourselves on the back, I think it's worth a sort of sobering reminder of history that the very first proven link between smoking and death, which was the link from the British doctor's study that showed if you were a heavy smoker, you're 25 times more likely to get lung cancer than a non-smoker. That was published in the British Medical Journal in 1954. 1954, when we incontrovertibly knew that this caused cancer and death. And here we are now over 70 years later. We're only just about, touch wood, to pass a new bit of legislation that will stop older teenagers from being able to buy this addictive drug on our high streets. So I think it's quite a sobering reminder of where we are. So in this tortured river analogy, where does smoking cessation sit? Is this Chepstow, is this Ross, or is this the hills of Wales? Well, I suggest to you it's all three. Primary prevention, if you take a teenager and you prevent them from ever taking up smoking, well, that's primary prevention, isn't it? If you take a middle-aged smoker who's just started to notice that their winter colds go down to their chest and linger a bit longer, and you manage to stop them smoking, that's probably secondary prevention. But what about tertiary? Well, there's an adage, isn't there, that it's never too late to stop smoking. And actually, if you were to only quit smoking on the very day of your lung cancer diagnosis, which for many smokers obviously is the doomsday scenario they fear the most, if you only quit smoking that day, there's amazing evidence of a dramatic improvement in survival, even at that late stage. The great news as well is the days of asking people to grit their teeth and just sort of ride their way cold turkey through those cravings are long gone. We've got behavioural support programs, we've got nicotine lozenges, gums, patches, sprays, we've got vapes, we've got varenicline, we've got cytosine. We have all these different things to help people quit. And I'm really proud of our healthy lifestyle service, and I put some of their figures on the bottom left there. The nice guideline is that we should aim for a minimum 4-week quit rate of 35%. So you can see that at 59%, we're doing really, really well. But there's still so much work to be done. I gave you that 11% prevalence figure. But of course, we all know that averages can hide a lot in healthcare, can't they? And there's some groups that have much, much higher rates of smoking. So we know our routine and manual workers, our people with mental health issues, our people who are in touch with the criminal justice system, all have much higher rates of smoking. So there's so much work to be done. But I think this is primary, secondary, tertiary, and a little bit like if you think about the core 20+5 for the NHS, it's a little bit like that. It cuts across all those areas, smoking cessation, which is why I wanted to leave it to last. I think there's also something here, of course, as well, finally, about our anchor institutions. And David, you were mentioning this earlier. You know, the council, the NHS, we're the biggest employers in Herefordshire, aren't we? Are we doing enough? I don't have local data for you, but there's we know that nationally in England, 73,000 NHS workers smoke, 73,000. And there's been some really interesting modelling that if you look at the cost of that, if you add it all up, the lost productivity from taking smoking breaks, the time off work from smoking-related illness, the cost to the NHS of treating the smoking-related illness, if you add all of that together, it comes to £2,800 per smoker per year. 2,800 per smoker per year. And then if you look at the cost per quit, there's a one-off of £117. I'll leave that hanging there. And my very last slide is just, I've drawn out the pathway of cardiovascular disease from wider determinants through to tertiary prevention. And this is just to show that it is a pathway, it is a journey, and there's opportunities for prevention every single step of that journey. And I think this is what one of the things I think is really exciting about Neighbourhood Health, is this is our chance to get on board something at the outset and think about how do we bake in prevention, and how do we use the energy, the enthusiasm, the commitment there is for Neighbourhood Health to make this the opportunity where finally we get prevention right. Thank you.
Thank you, David.
So it's not a question, it's just something to add to the conversation that we're currently doing a piece of work at the moment to look at trying to help people stop smoking and lose weight before surgery. I mean, you all know this as a GP and a public health person. Length of stay is shorter, health outcomes are better, and the chances of recovering fully are better if we do that. So I think that's almost, what would you call, the fourth phase of prevention. You know, they're going in for surgery and trying to help them at that point, because even the evidence is at that point it can make a significant impact on people's health outcomes. So just something to add to the equation on what we're doing locally in that area.
Putting my day job hat on for a second in terms of physical activity and prevention, I would say it was right up there with smoke cessation in terms of getting people active and physically active. The evidence base is very strong for that as well. So just factor that into your thinking, and if you'd like a more in-depth conversation, then I would happily do that. Putting the VCSE hat back on in terms of Neighbourhood Health, in terms of those consistent messages running through, I think there's a role for the VCS to amplify those messages, in terms of they might not necessarily be specialists in smoking cessation and physical activity, but they can certainly amplify the message in terms of the Neighbourhood Health, and potentially be part of the solution going forward.
Thanks, David. So you've just made me think around NHS and the council being anchor institutions, and around smoking. So we've got a whole load of senior leaders who sit together within the One Herefordshire partnership. So I think there's something we need to do where we agree to, you know, a number of targets across that, and we agree what we're going to do for the next 12 months to, you know, prevent more people from smoking, I think, within our organisation. So I think that's something we do need to look at as a priority.
Yes, thank you. Yeah, I've got two awards for David. One is Best Analogy of the Year. I think that's fantastic. I live in the world of analogies to make my point, and the River Wye, using it so vividly to articulate those three key points, I think is really, really powerful. And also it's Presentation of the Year for me, because it tells a story. And a story, you know, a message lands when you tell a story, and that's a very vivid story that we need to tell everyone on this journey about improving health outcomes. the progress that's been made with regard to cessation of smoking has been huge, and sometimes we're in danger of forgetting just how successful the program is. The only thing that concerns me, though, is that it's now embedded in everyone's consciousness about how dangerous and bad for health smoking is, and it's now become a widespread message. What I worry about, though, is that there are other messages that aren't landing, and I'm thinking in particular with regard to nutrition and the lack of awareness that the wrong nutrition can lead to very bad health outcomes as well. And one only has to go into a supermarket and it'd be easy to point out all of the things that are quite harmful to health if not consumed in moderation. But we don't have the same story, the narrative that we do with smoking. So I think one of the next tasks we will have to have is one about the importance of good nutrition and how it supports good health. And that's part of being right at the source of the stream, really, and making sure that's embedded in all of the narratives that we do. Because if you have poor nutrition or the wrong nutrition, that can really affect health outcomes. So it's knowing how we can have the same impact that we're having with smoking that we can on choices when it comes to nutrition. And I think we need to put more thought and emphasis on that moving forward for all kinds of reasons, obesity and dental health decay being two of the first things that are in my mind.
Thank you. I think one of the things that I discussed this with David on Friday, and with Chris Whitty. Vaping is really good when someone who has been a smoker for a long period of time takes the decision to stop smoking and to vape. We don't know enough about the implications of vaping yet. As you say, we didn't know about smoking until the 50s. And people have been smoking a lot longer than that. But the problem we've got is we've got children as young as 10 who are vaping who might never have taken up smoking. And that is a really, really difficult thing to crack. And when you stated yesterday that in an ideal world, we would say, smoking is on prescription for those, vaping is on prescription for those that smoke and need a means of getting off smoking. But we can't do that because there is no way of putting vaping into a prescription drug. And so therefore people will continue at a very young age to buy it when we wouldn't have wanted them to. I was quite startled by that and quite alarmed. But it was, yeah, David.
Sorry, yes, I absolutely agree with you, Councillor Andy. I was just going to come in to clarify the point, because I think this is often confusing for the public, and it's not the situation we would necessarily have wanted from a public health point of view. I think it's important to state that actually vapes have been around for possibly longer than people think. The first electronic cigarettes were invented in China, I think in 2003, something like that. So they have been around a fair amount of time. There is actually, although we don't have the long-term data, the data is getting longer. And I think what was Public Health England, now OHID, have done a number of evidence reviews. I think they're on something like the 8th evidence review of this. And the guidance that vapes are at least 95% safer than cigarettes has remained constant. So it's 1/20th of the risk. And this is the problem in the public's perception. Nicotine is seen as the bad guy. But actually, nicotine is in that it's hugely addictive, and that's why people want cigarettes. But actually, nicotine's probably not much more dangerous as a drug than caffeine. The dangerous bit is all the tar and all the other awful chemicals that are in it. So we do know that vapes are so much safer than cigarettes. But there's these two ideas, you're quite right. They're a brilliant medicinal product. They're a brilliant stop smoking aid for all sorts of reasons, because they allow people that habit of being able to use their hands, of being able to sip and get just the dose of nicotine they need. So they work really, really well. But at the same time, we don't want young people using them. We don't want people who've never smoked to use them. So the advice is, yes, if you want to quit smoking and this is something you're interested in, this can be a really powerful tool to use. But if you're a child or a teenager and you've never smoked, you should never vape. And I think it's perhaps a slightly subtle message, but we all have a role in putting that message out there and keeping it out there. Thank you.
Zoe?
Yeah, and I think the presentation's really useful, David, in terms of taking us through as a board, thinking about that whole spectrum of prevention, from the primary through to the tertiary, and that actually neighbourhood health is an opportunity for us to really focus across that whole spectrum of prevention. As a Health and Wellbeing Board, we're much more used to thinking about that primary prevention, and we've got a job to do in terms of refreshing our strategy and thinking about, is it smoking, is it diet, what is it we're focusing on, what does our data tell us, where are our priorities? And that's the big picture side, isn't it, around primary prevention as a board that we know we've got to do in the year ahead. I think neighbourhood health, a bit more rapid, gives us an opportunity. We need to write the neighbourhood health plan. So that gives us an opportunity to think about the cohort that we've identified, that 1,000 or so people that are already the four long-term conditions, 1 hospital admission. Actually, what do we do in terms of prevention for those people that we know are going to tip over into being that 1,000 odd people? That we can identify through our data and say they're most at risk in 2, 3, 4, 5 years' time. So we're not talking 10 or 20 years, we're talking about that bit that's very much in the land of that sort of secondary prevention, going, we know these people are at risk and we need to stop that from happening now, to stop that 1,000 cohort growing to being 2,000, 3,000. And we've got a job to do in that space as well. So I think it's having a focus on both of those through neighbourhood health and then through us as a Health and Wellbeing Board in terms of the whole picture and primary prevention. And then the third bit to the picture has been touched upon a couple of times here in terms of our role as anchor institutions, anchor organisations as well. And I think there's real value that we're probably not capitalising on as well as we could. And we really should be doing that through the Health and Wellbeing Board as well.
Right, so if I take this back a bit to neighbourhood health and the mention within there of minor injuries units, which there was a mention, I'd now like to ask Ed if he'd like to present his ideas, arguments, etc., etc.
Thank you, Chair. There's a segue, really, before I start. I had a heart attack in 22, and I had an MSTEMI, and I found this conversation has been very interesting. It's brought a lot back, actually. I was doing a 5K charity run, and Couch to 5K turned into Couch to A&E, unfortunately. It was a difficult time. It had been going on for about an hour, the heart attack. I rang for an ambulance. Unfortunately, the ambulance was going to be 2 or 3 hours, so in the end we had to make our own way to Hereford Hospital. And when I got to Hereford Hospital, unfortunately, I think you were under a lot of pressure at that point. There was a handwritten note in A&E that said there's currently a 17-hour wait to be seen. I reported I had chest pain. I stood there for about half an hour, 40 minutes, and it subsided, whatever it was. I wasn't sure it was a heart attack. I didn't know what it was. So don't ever do this, folks at home, if you're watching. I went home, and fortunately I phoned pending surgery the next morning, and within an hour I was getting back to SDEC, and I had a blood test, and I'd had a major coronary event, and I then spent about 2 days waiting to get a bed, sadly, because you're under a lot of pressure. But once I did get a bed, it was fantastic. I was treated really well. I went to Worcester, and I had a large stent fitted. And then I got to experience the wonderful tertiary prevention that we've been talking about here. And I have to say, the rehabilitation that I had at Ross was amazing. The team are great. They're fantastic. And since 22, I've lost 4 stone. I go to the gym every day, and touch wood, I take what I need to take. But it's been a good journey. But I've been one of the lucky ones. It could have gone very, very differently. Because of what happened, I've spent a lot of time still going to the doctor's surgery from time to time. I know the staff down there quite well. I talk to them in Ross, at the various surgeries at Alton Street, at the community hospital, and obviously at Pendine. And I can't thank them enough for the actions they took quickly when I went through that. And one of the things they all think, and I do agree with them, is that the pressures on A&E could be dramatically reduced if the minor injuries units were reintroduced. Our county is growing. They want our county to grow a lot quicker. We've all seen the plans, the number of houses that are coming on board over the next few years. I was talking to one of the senior staff at one of the health centres over the weekend, and they all think it's a no-brainer. The first thing you see when you turn up at Pendine Surgery, on the middle of the door and the entrance, is a list of where the minor injuries units are around. They're sending them to Cinderford, they're sending them to Ledbury, and it says this is where you need to go. And transport is a real challenge for our county, sadly. And if you have a minor injury, and as we've said here earlier today, you don't have a car, or you only have one car and that's being used for something else, finding the time to go to get to Hereford, or physically having the time, having the means to get to Hereford in anything like the space of time that's required is a real challenge. It's really difficult for a lot of people. And having those kind of facilities, having minor injuries units, not necessarily as they were before. I think we all agree that time's moved on, but there is a need for a resource that can look after our communities within their community. Ledbury still has some form of minor injuries unit, and Ross are two great examples where I think we can help to take some pressure off the A&E. I know our communities want it. There was a petition in Ross, I think it was when it was temporarily closed down, the minor injuries unit. I think, correct me if I'm wrong, but it hasn't been properly closed down, because for it to be closed down, there would actually have to be a proper public consultation, which has never taken place. There was a petition raised, well over 10,000 signatures, wanting to get the minor injuries unit reopened. It's there's real passion and need and understanding that it's something that was an important resource for the town. And I think when figures were looked at, and the way the hours were reduced over time, and how it was compared to its usage was compared to other areas, I think that could be looked at again quite closely, because I don't think the hours were balanced quite as fairly as they could have been at the time, from how I understand the way it worked. And I would really urge and ask everybody around this table to look carefully at how our minor injuries units could be brought back across the county. We are growing. We do need to listen to our residents. I've had lots of communications from senior health professionals. I'm not going to name names, but also doctors from the A&E have messaged me in Hereford saying this is a no-brainer. We just need to get it right. I've also had people that have phoned me and saying their lives were saved because of minor injuries units. I had one resident who'd had a reaction to a bee sting. Fortunately, they were able to save her life, and that was at Ross-on-Wye. So I do think it's important, and I urge everybody to see what we can do to try and bring them back. Thank you.
Would you like to comment, Sarah?
Yes. So I spoke to a lot of people since coming into post, so bearing in mind sort of 10, 11 weeks in, and I've looked at some of the data, around at the point when the decision was made to temporarily close the walk-in centres, and they were seeing approximately one patient an hour. Now that's in order, because walk-in centres are quite isolated in their nature. You are talking about senior health professionals, so either a junior doctor or an emergency nurse practitioner or an advanced nurse practitioner. So the decision was made, as you know, is to relocate those individuals back into accident and emergency. Now, if we were to look at a business case to reopen those walk-in centres, minor injury units, it wouldn't be cost effective for one, you know, for them to be seeing one person an hour. And where we are is basically in the neighbourhood health spaces that we do put something into local communities, which actually further extends the offer than just a kind of a minor injuries unit. And when we look at certainly for Hereford, which we are different to other you know, systems across the country, our non-admitted performance, which is those patients who come in and get seen within 4 hours and then discharged back out into the community, our performance is very, very good in that space. Our issue is patients who require inpatient admission, so our admitted performance is not where it needs to be. It's improving, but not where it needs to be, which is actually due to flow within our inpatient beds and being able to discharge sooner or avoid admissions altogether. So the pressure isn't on those minor injury walk-in centre patients within the ED. So your unfortunate wait for 17 hours to be triaged and seen, it's not that group of patients who are actually placing that pressure on our A&E at the moment. So I think we need to really be looking at, as we've heard described, is that neighbourhood health, community health model, where it does give the local communities an anchor in their community.
Thank you, Sarah. Can I just challenge those figures, though, because these are figures that were used in the past, the 1 per hour. As I understand it, that was 1 per hour if you divided the number of patients that were being seen by the total number of hours in a week, so 24 hours, 7 days a week. And actually, it didn't take into consideration the fact that the minor injuries unit was only open for a limited number of hours, I think 5 or 6 days a week. So I think I'd like you to check those figures, because I was told that that those figures, as they were quoted, as you just quoted them, then were actually incorrect. You know, I do not understand why Ross and Wye, which with a catchment area of about 5 miles, we're close to 30,000 people in that area, why we would be different to Cinderford in the Forest of Dean, why we would be different to Worcestershire, to all of the minor injuries units you've got across the whole of Worcestershire. Is there something different about Ross and Leominster as communities that people don't have minor injuries? I don't think that's the case. If the model works elsewhere, why doesn't it work in Herefordshire?
I mean, if I just put over to Dave, I'll go to David, but just to answer around around the figures, I will go back and just double check, as I'm taking it from what has been said previously. You can answer that, okay? But around why is it different, and as I said before, I've been in Worcester for 2.5 years, and the pressure on the A&E department in Worcester is a little bit different, because they struggle also with the non-admitted performance. So patients in Worcester ED are waiting longer than 4 hours, and that then means that the commissioners need to think of something different around that local population. But I'll let David come in on that piece.
So I'll answer the question about the data first. No, it wasn't calculated over 24 hours. We look at the number of patients seen each day, and on average it was 6 to 8 patients a day, which, when you look at a unit that's open 8 hours a day, that's patient an hour. So it was absolutely, I mean, that would be a wrong way to calculate activity through a unit. So just to be clear on that point. I think the other thing that's worth saying as well is that I think we need to look at this in the context of all the other services that are new in the area now that weren't in place at the time of the closure. So if I just look down a list of a couple of things that I'm aware of. So GP practices obviously have always been there, but GP practices are now offering 3,500 appointments a day across Herefordshire. That's a lot higher than it was back in 2019. We've got something called same-day urgent care access hubs. Same-day urgent access hubs, you've got to get the letters in the right order. They're seeing about 23,000 appointments a year that didn't exist back then, and those are all over Herefordshire. We've got the extended access hubs, so in general practice, which is open from 6:30 in the evening till 8 o'clock in the evening, and on a Saturday, they're seeing an extra 7,000 patients a week that they didn't see before. And we've got something called the Herefordshire Remote Health, which is like an online service provided by Taurus, which is accessible to people not face-to-face, but through telephone and online appointments. And they see about 85 patients a day. So none of those services, apart from core general practice, were in place there. So one of the things we have been trying to do over the years is to make these services accessible to everybody across the whole county. Whereas obviously the issue about locating a minor injury unit in one town is it's very accessible to that town only, but not to the wider community. So I just think that's important context to think about in the wider health strategy that we're doing. But that's not to say that when we move on to talk about the 10-year plan and implementing neighbourhood health, that there's something else that we can do, that we can look at those facilities. We've got a great network of community hospitals, got GP practices, we've got all kinds of other health buildings dotted around, and partner buildings dotted around the county. It's not to say that we can't look at those differently and work out what the best use of those facilities is going forward. And I think that's where the opportunity arises for us. What conditions can we treat closer to people's homes? What professionals do we need to employ to be able to treat those conditions? And how can we make that healthcare more accessible? Because ultimately, if we take David's analogy to its extreme, well down the Bristol Channel is where the health service picks up a lot of these things that didn't work previously. We have an interest in making all of this work, but still being there to provide accessible care close to home as quickly as possible, provided by the right professional in the right way. So absolutely open for working with local communities, local members to work out the best way of doing that through the Neighbourhood Health Programme.
Can I just ask a question? You mentioned a number of different organisations there. Where are they based? Because some of those I've never even heard of.
So the extended access hubs, there's one in each primary care network area. So we've got five PCNs.
So how do we know where they are? So how do I, as a resident in the northwest, how do I know where my unit is?
So my understanding is that you don't need to. That what will happen is that you phone up your general practice as per usual to make an appointment.
But I don't. I have to fill a form in.
So I think then when they allocate you an appointment, they would give you the option of having an extended access. So you might be able to be seen by the extended access hub a little bit sooner.
Never had it mentioned, ever. So that is something new to me. So what else did you mention there?
So we've got extended access hubs, which say attached to your main GP practice. But as David says, the point of this is stuff that's going on behind the scenes. So this is longer opening hours and Saturday opening hours. So if it's all right for you to give you an appointment in the evening rather than during the day or on Saturday, then you would be offered that appointment. It's additional capacity. Right. It's not something that you would necessarily phone up as a local person and say, I'd like to see
it's never been offered, so I didn't even know it existed.
And same-day urgent access hubs, which is a particular way in which primary care works to make sure that people who need urgent primary care access can get it rather than wait.
I understand that.
And then the Herefordshire Remote Health, that is probably, I would imagine, again, that's directed through the local GP if they can say that you could get some remote support here. I'd have to check on the remote health one. That's a smaller aspect of the service.
Yes, David.
I think it's a similar idea. Each practice will have a certain quota of those appointments, and so they can offer them to patients. And I think the extended access, that would just be within your PCN. Your practice will be a member of a PCN. It'd be one, there'll be a rota with each practice in the PCN offering a certain number of those appointments at certain times.
I take your word for it. I will check it out.
Thank you, Chair. Yeah, I'd love to see those figures. That would be great. If you could provide me with the figures, the actual admission figures, I'd really because some colleagues will want to see those as well. I think when we're talking about these hubs, what we're actually talking about is additional capacity within existing practices, isn't it? We call it a hub, but what it might mean is that there's more hours at the surgeries in Ross-on-Wye outside of the usual 9 to 5 or the 8 till 5 when the doctors are seeing people. So rather than a new build somewhere, which often is what a hub sounds like, it's not a new building, it's not something else, it's a little bit more money we've given so that we can extend the capacity of these of existing surgeries and practices to see more people. That's correct, isn't it?
That is correct, and that is often the most cost-effective way of getting additional capacity in, rather than opening new buildings.
Sure. It just, when you say we've got a new hub here and we've got a new hub here, actually we've got, it's the same building, but it's open for longer, I think is possibly a better way of putting it.
Classic NHS term.
Yeah, I know, but if people are going to play this back, I think it's important they understand what we're talking about.
It could include minor injuries units, which are buildings which already exist.
Yeah, it could, which would be fantastic. I am concerned. We had the motion came through. The councillors, we hope, I know a lot of them really do have their ears to the ground and understand what their communities need and want. And they voted, I think, virtually unanimously to bring back the minor injuries units in Herefordshire. There was a real sense of loss when they were closed down. And I beg you to reconsider and to think about and talk to. I know you're doing this a lot, but I've been talking to frontline staff, and they seem to think it's a no-brainer. And I don't. We've got equipment, we've got great radiology equipment in Ross that isn't perhaps being maximised and used as much as it could be potentially. That's one of the things I'm hearing. And let's look at how we can use these resources sensibly, efficiently. And yet, if we are going to come up with a new neighbourhood model, let's look if there's a way of people being able to get their stitches taken out without having to get on a bus and go to Hereford to have it done. So it takes them a whole day off work to get it sorted, which they used to be able to do at the minor injuries unit. Those kind of things, that's what I'm hearing, that's what people need, that's what people miss. I think that there is a wealth of experience in the councillors, and there was a real feeling that minor injuries units is a resource that we're lacking. And I'd like to ask one more thing. If you do decide they're not coming back, then I think we have to insist that we have the public consultation. Thank you.
Thank you. I was just going to say, as part of the Neighbourhood Health work, it would be good to catch up and come and sort of engage with the communities with you and think about opportunities for the building, think about neighbourhood health centres in the future, and just as part of our programme, part of the wider piece of work, just come and have a conversation.
Jo, that would be very helpful. Thank you.
I think we're not saying that there doesn't need to be anything in Ross or in the other areas at all. I think we're just starting now which I've commissioned, a strategic review of our community hospitals in line with the Neighbourhood Health programme. So we actually can look collectively with partners about what actually do we need our community hospitals to be delivering. So that will be part of the programme. So I think linking with Jo and some other members of that team. So we're not dismissing. It's just that there's more that we can offer within the neighbourhood health space that we need to crack on with.
There are a number of recommendations here. Is it possible to put them up on the screen? Rather than me read them all out.
A to B, A and B there.
And then there's F, right to F at the end. It's quite a lot. If it's a problem, I can read them out.
Those are up on the
They're on the screen?
screen, yeah.
Right. So the first recommendation, which is to note the new requirements set out in the draft neighbourhood framework. Everybody okay with that one? The second one is endorsing the proposed approach to develop these plans. Everybody happy with that one? The third one is to confirm that HWB members to lead and attend task and finish group for strategic plan development. And I presume we will sort out who goes in the future. Okay. Fourth one is to note the progress to date with the NNHIP, which is the Neighbourhood Health Implementation Programme. The fifth one is the Health and Wellbeing Board to agree further progress updates at each meeting and provide a strategic direction. And the fifth one is to endorse the proposed change in structure of the One Herefordshire Partnership Governance. Okay, all those in favour?
You might correct that.
Chair, it's C is confirm Health and Wellbeing Board members to lead and attend the. Who's going to lead? And beyond the task and finish group.
That's what we said we would sort out. We'll sort that out outside of the meeting, I think, won't we?
Oh, okay.
We haven't got that far yet down the line, I don't think.
Okay.
All right. So, all those, a proposer, seconder, all those in favour? Any against? No, thank you. Ed, if you wish to go, fine, thank you.
Chair, can I just give my apologies? I've got to go to do a press interview. So.
Right.
Okay, thank you.
So we now move on to agenda item 8, which is the implementation of the Neighbourhood Health Framework, responsibilities and approach for the Health and Wellbeing Board. And this is a report by Joe Hodges. Oh, we've just done that one. Sorry. Well, I'm on the wrong page here. So we're now on to 10, which is the annual report of the Herefordshire Adult Safeguarding Board. Kevin isn't here. You'd be able. Yes, Hilary. Thank you.
Thank you, Chair. So you have in front of you the 2024-25 annual report of the Herefordshire Safeguarding Adults Board. It's being shared with members of this board for consideration and to provide assurance around the arrangements for safeguarding adults in Herefordshire. It's a statutory requirement that this annual report is shared with the chair of this board, and consequently we're sharing it with the wider board. It has been approved by the Safeguarding Adults Board and published in October. Herefordshire Safeguarding Adults Board continues to fulfil its 3 core duties, and they are to publish a strategic plan, to publish an annual report, as you see before you, and to conduct safeguarding adult reviews. As you'll see from the report, we had an increase in referrals for potential safeguarding adult reviews. There were 16 referrals compared with 5 in the previous year. 5 of the 16 were found to meet the criteria for a review under the Care Act, and those reviews are either in progress or published. 1 safeguarding adults review has been published, which is under the pseudonym of Carol and Susan. In terms of performance indicators, they continue to show similar trends to previous years. The number of people in Herefordshire who say they feel safe continues to be higher than the West Midlands and England average, although there was a small decrease compared with the previous year. The number of safeguarding concerns and safeguarding inquiries has fallen. I think we just have to be careful about looking at that, because that's due to a difference in the way in which we are triaging inquiries. So it's not necessarily that they've fallen, it's just that they're dealt with and triaged at an earlier point. And I think we'll get better comparisons next year. Majority of those subject to abuse were females, and the most common location of abuse was in a person's own home. We have got a strategic plan, which, as I say, is one of our core priorities, and we continue to operate the subgroups that deliver against that plan, and we have progressed. There has been some drift in terms of the plan, largely due to staffing capacity within the partner agencies. The current strategic plan is for a 3-year period and it runs out next year. So we're in the final year and we're beginning discussions about what our strategic priorities should be going forward. We held a development day earlier this month and that is starting to inform the plan for the next 3 years. I'm sure members will have seen we're also currently advertising for the role of independent chair. As the current chair, Kevin, who unfortunately can't be here today, his term ends at the end of March and he's indicating that he will not be continuing. So we will have a new chair of the board, all being well with the recruitment, effective from April next year. I'm very happy to answer any questions, Chair.
Before I take questions, could I just put on record our thanks to Kevin Crompton for the work that he has done, both for the Adult Safeguarding Board, but also for the Children's Safeguarding Board. He's done an excellent job and he will be a hard act to follow. Thank you. Any questions? No? Okay, so we go back then to the recommendations, which are that the Health and Wellbeing Board considers the Herefordshire Safeguarding Adults Board Annual Report 24-25 and discusses the effectiveness, etc., of safeguarding adults in Herefordshire. Proposer? Seconder? All those in favour? Thank you. We move on now to item 11, which is the Health 2025 Health Protection Annual Report, and this will be presented by Rob Davis, Consultant in Public Health. Thank you.
Thank you, Chair. So in front of you, you do have our 2025 annual report from the Health Protection Assurance Forum, which is a subgroup of this board. It's a forum, for those not familiar, of public health professionals, the NHS, UK Health Security Agency, NHS England, Environmental Health and others. So it's a true partnership that is tasked with providing the glue that assures that for our Herefordshire residents we are doing our utmost to ensure that they are protected across a range of communicable disease threats, environmental hazards. They're up to date with screening. We're rolling out vaccination programs and other things to prevent future illness as best as we can and as equitably as we can. So just a thanks again to all our colleagues for that collaborative effort, which is vast throughout the year. The detail is in the report in your packs. I've just got 3 slides to tease out a few key outcomes during the year. The results of an external audit, which we have completed, and a little bit about the future direction that we're planning for 2026. So in terms of some key achievements, we manage roughly 100 outbreaks in the community a year. Now the goal of this is to ensure that small fires, 1s and 2s and 3s in nurseries, hospital and other venues are stamped out before they become wider and start going around in the community. And we've had no major out of the ordinary outbreaks this year, which we're proud of. In terms of collaborating with national colleagues on cancer screening prevention, across the board, our cancer screening programs perform very well. They're at national average or above. There's always work to do because some of those national trends are stationary or rising at a slow rate, where we would prefer them to be even better. But comparing against colleagues and neighbouring local authorities in our region and elsewhere, we are generally at or above average. We continue to be a very low tuberculosis area, in contrast to other areas around us or in our major cities have had major outbreaks this year. And we are amongst the top in region amongst preschool vaccinations. So as an example, MMR, measles, mumps and rubella, many outbreaks, many cases in urban areas like Leicester, Birmingham, even Worcestershire, whereas we have very, very few cases because our vaccination rates are amongst the highest, and they've just tipped into the technically 94.9, but almost 95% recommended for dose 1, which has been a tough road to get that up and bucks a national trend of declining. vaccinations. So the general picture for Herefordshire is Herefordshire residents, parents often do the best and try and maximise their vaccine uptake. We've got feedback from different groups that the main reasons they often don't take them up are just they've missed an appointment, they haven't rearranged it. So our challenge is to make it as easy as possible to allow those parents to do what they already want to do. We've got specific work last year with Looked After Children, which was the LAC acronym bottom left. So as part of our corporate parenting offer as the council, we do our best to ensure that our Looked After Children have at or above the care and responsibilities as any other child would have. These are a small group of children who have more complicated lives than average, so they're more likely to miss appointments. So we've engaged quite rapidly and multiple times throughout the year to ensure that they've got reminders on their records, they've got multiple safeguards where they can catch up on missed vaccines or be reminded on different systems around the council and NHS to prompt that uptake. And we're looking forward to seeing the results of that targeted work throughout this winter. In terms of, so the previous slide was more on outcomes, like what are the results of our work. This is how we're doing the work. So we got in some external auditors who are from the UK Health Security Agency. They were able to check and challenge us across 105 audit standards developed by the Association of Directors of Public Health, a standard quality improvement exercise, colloquially known as what good looks like. So we're very pleased with the outcome of that, that showed that across 99 of the 105 we fully met the criteria. That essentially means the process is in place, the way we're working is as good as it can be and is effective based on the needs that we're seeing in our community. It wasn't perfect, and I've got a few of the things up on the slides about what we'll be working on further. Just to draw your attention on the not met. So I mentioned we're outstanding on our first dose of measles, mumps and rubella. We're a little off on our second dose, although to be fair, that is an ongoing national challenge, and they are moving the timing of that second dose to make it easier for people to get 2 doses closer together. So we're hoping that that national approach and a little bit of local work that we're going to do will bring us up to that in the 6 months or year to come. So that's a key one for us on what we're hoping to change. In terms of the ongoing challenges and risks, as I mentioned, some of the vaccine preventable diseases are high but static. There's thresholds that were ideally above 95%. Some of our vaccine preventable disease coverage is around 90%. We still want to go from good to great and hit that milestone. That's an ongoing target for us. Nationally, cervical screening uptake for younger groups, 24 to 29, is on the decline, and we see that as well in Herefordshire. So we're working specifically with our NHS colleagues to not only promote what they've got planned in the year, but whether we need any more focused tailoring locally to even go above that to maintain our above average status. In terms of wider harm around drugs and alcohol, we have seen an increase in referrals into drug and alcohol services and an increase in drug-related deaths relative to last year. So we're folding in those improvement plans into our assurance function and tracking those throughout the year as well. But we just wanted to note that that is one of the pictures that's changing in a slightly negative direction. But there are plans in place to rectify that, including review panels and learning all you can from every single drug-related death and feeding that into more preventative activities. Another one just to flag is our breast screening location, breast cancer screening location, which was originally a nice hub in a supermarket, but had to move around a little bit. But we got feedback that people like to know where it is. They like to know that when their screening call comes, they've got a simple way of doing it. They can integrate it with their shop. So we're working hard just to maintain that a secure, stable site so we can get back in the flow. And we do believe we've got that with Asda again. Yeah.
And just to the people that there was a hiatus between it going from Morrison's and being relocated to Asda,
Yeah.
we said that we would try to make sure that those people that were called up between that period were and might not have attended because they'd have to go to Ross probably, that they would be recalled to make sure we didn't miss anybody. That has happened, has it?
I might have to refer to Zoe on that one, thank you.
We did have that promise, and we need to go back and make sure that that has actually happened, because there was a 3-month period.
At least 3 months.
Yeah, and we can check that, because actually we were told that they would recall those people. So
I just want
check that.
to be sure they did recall those people. If they choose not to turn up, that's their choice. But we must make sure that we've covered that gap where it was probably more difficult for them to get to Ross.
Yeah, you're right, there was that period, and we've got that assurance that they're checking, but we can follow that up, that that's been actioned fully. In terms of the future focus, which is plans for 2026, we are looking to improve those not met or partially met elements of our audit. We're looking to maintain our good practice in childhood immunisations. Like I said, there are some subtle tweaks that should improve access locally and nationally. We just want to make sure that goes smoothly and that doesn't create a ripple in our good performance. And there's another element of, while health and social care staff dealing or in close proximity to older adults who are more at risk of the more severe elements of flu, are maximising their uptake. We are trying to make that as easy as possible for them to get that either at work. There's different offers via the NHS, residential homes with GPs vaccinating the residents and then offering it to the staff at the same time, so it's convenient. We could probably do more and are looking to do more to maximise that uptake in that specific group. The finalisation of the Asda site on Herefordshire as well is on that slide. We think we're 90% there, which is a small win going into the new year, so we shouldn't have a repeat of that gap, but we want to keep that as a regular service so people get used to seeing it, and we know that makes it more likely that they will turn up and have the screening that most women choose to do. The others are related to drug and alcohol services and increasing the cervical cancer screening uptake, which is a national initiative as well as Herefordshire, but is also a priority for us. That's the kind of overview there. I can take questions.
There's just a comment really about figures. So in the report it says, in 2024-25, Turning Point received 956 referrals. This is 16% more than the previous year, which was 153. Now, I'm not very good at maths, but I don't think that is right.
That doesn't sound right off the top of my head, Chair. I can certainly look into that and add a clarification if needed.
Right, okay, thank you.
Sorry, that was the end of the future focus slide. So yes, questions either now or also proposals for the assurance forum to follow up outside of the meeting as well.
Anybody got any questions? Oh, yes.
Thank you. My question is just around on your last slide there about the uptake of flu vaccinations in the health and social care workforce. Has any consideration been given to flu vaccination for the education workforce? We know that in some of our schools we've had to close classes because of staff absence, because staff have had flu, or because the number of children, so they are super spreaders so as places. So I was just wondering if any consideration had been given to them.
Yeah, we review our flu offer each year from the council perspective, if they're direct employers. There's also an NHS offer which does sometimes change the criteria each year. So at the moment the NHS offer is health and social care staff and people with different conditions that make them more vulnerable. Our in-house offer follows that guidance at the moment, so it is restricted to health and social care. We have had specific requests from educational colleagues. If they can make a case that they're in contact with specific high-risk groups, then they will probably be eligible for reimbursement. But we run that in previous years, and we've had the cohorts be so low, we're talking 1s and 2s, that the last judgment that wasn't a cost-effective use of the council's provision, but we do routinely consider that cohort each year. So if there's a fresh case to be made, we're more than willing to consider it.
Anybody else got any questions? No. So we go back to the recommendations, which is the Health and Wellbeing Board note the health protection system's performance achievements and risks, as well as the areas of focus for 2026, and the Health and Wellbeing Board seek any further assurance via the Health Protection Assurance Forum. Do I have a proposer? I'll propose it this way. And Hilary second it. Okay. We move on to item 12, which is the Better Care Fund.
Excuse me, Chair. Sincere apologies. I've got to go. I've got to go and retrieve a stranded child. Do apologise.
That's fine. Absolutely. No problem at all. Thanks, Steve. So item 12 is Better Care Fund, quarter 2 for 25-26, and this will be presented by Hilary. Thank you.
Thank you, Chair. Yet again, because of the timings, we always have to retrospectively approve the template submitted. So this is the quarter 2 template for the Better Care Fund that was submitted in November. As you know, our original Better Care Fund fund was approved for this year, but it had conditions, one of which was to produce a delivery plan. That delivery plan is now in place. A significant focus of that delivery plan is around a revised model for our discharge to assess. You will see both from the finances and the performance indicators, that's an area of pressure for us, and we are working hard to both mitigate the financial pressure as well as to improve the performance. So other than that, we met all of the National Better Care Fund conditions, and as I say, we have the delivery plan. In terms of performance, we're on track for 2 of the indicators, so the indicators around emergency admissions and the long-term admissions to residential and nursing care. Where we're off track currently is around discharge delays, and as I say, we are doing a lot of work in that area around action plans, improvements to Pathway 1 and use of community hospital beds. In terms of the funding, as you can see, Better Care Fund is currently reporting an overspend, and that is predominantly due to overspending on discharge to assess and a small proportion on deprivation of liberty standards. We have a number of savings and mitigation plans that we're working through, and these are being prioritised to control expenditure and minimise overspending by the end of the financial year. Clearly, there's a risk still that we fail to achieve the national metrics, and we have, as we often report in this board, that rising demand from our population, which is having an impact on the performance, particularly around discharge to assess. There are plenty of mitigations in place, but clearly that is with a demand-led service, it is not always easy to be absolutely accurate, but a revised model is being worked through. Happy to try and answer any questions, Chair.
Anybody have any questions regarding this? No? No, that's fine then. We go back to the recommendations. So the recommendation is that the Better Care Fund Quarter 2 report Appendix 1 submitted to NHS England be reviewed and approved retrospectively by the board, and that the ongoing work to support integrated healthcare provision that is funded via the BCF is noted by the board. I have a proposer. Seconder. All those in favour? That's it. Fine, thank you. We now move to item 13, which is dates of future meetings. The updated work programme has been circulated in the agenda for review by the board. In addition, board members are reminded of the intention to hold a board development workshop facilitated by the Local Government Association on the 12th of January. Is there a problem for anybody on the 12th of January? There is for you, David.
I'll be on leave.
You'll be on leave.
I'm on leave.
You'll be sunning yourself somewhere, will you?
Not quite. I
Oh.
shall be in the Forest of Dean, but I shall be on leave.
Quite Mauritius.
Oh dear. But apart from that, everybody's able.
If I may, the intention there potentially is to hold that at 1 p.m, so slightly earlier, just to give the board time to meet and do everything it needs to do at the
That's
workshop.
fine.
So we'll circulate an appointment
You'll circulate
tomorrow.
that.
Yeah.
That's fine. Okay. I think that would be difficult to hold that for anybody wanting to attend virtually. I mean, I don't know. What do you think?
I think in person.
It has to be face to face. I think it's really difficult to hold a workshop with people coming in on virtually. So I think we need to make it clear that this is a face to face meeting. Okay. The dates have been circulated for future meetings, haven't they? You sent the list out.
Yes, Chair, and certainly they're in the agenda at page 259. So there's also a board bill workshop proposed on the 9th of February at 2 p.m, so that'll cover Neighbourhood Health. And then our next actual formal meeting would be Monday the 9th of March. Following that, picking out the point that that all picked up earlier, was we intend to try and put it in order so that the Better Care Fund falls more appropriately for approvals prior to the submission date, so that it's not in a situation where we're giving retrospective approval. So future dates will then follow a kind of a May, July, October and January format.
Okay then. If there's no other business, I close the meeting. Thank you very much.